will be discussing about peritonsillar abscess or Quinsy. What is peritonsillar abscess? Peritonsillar abscess is a deep neck space infection. Peritonsillar abscess is collection of pus in the peritonsillar space. The peritonsillar space is a potential space between the fibrous capsule of the tonsil and the superior constrictor muscle. Superior constrictor muscle will be lateral and the capsule of the tonsil will be medial. So medially there is fibrous capsule of the tonsil that is part of the pharyngobasilar fascia. Laterally you have the superior constrictor muscle. What is anterior and posterior? You have the anterior pillar and posterior pillar. Anterior pillar is part of palatoglossus muscle, posterior pillar is palatopharyngeus muscle. What is superior and inferior? Superiorly you have the torus of the eustachian tube and inferiorly you have the pyriform sinus of the hypopharynx. That is a peritonsillar space. Why it is a potential space? Because it can expand and the pus can fill into the space. That is why it is known as a potential space. The problem with the peritonsillar abscess is it has connection to all these areas and that can spread to the surrounding structures faster. The peritonsillar space contains loose areolar tissue which helps in rapid expansion and spreading of the abscess into the parapharyngeal space, base of tongue, etc. What is the etiology? The infection usually comes from a tonsillitis and it enters into the peritonsillar space. It invades the peritonsillar space via the crypta magna, that is a remnant of the second pharyngeal pouch. It can enter into the peritonsillar space. And also there can be infection of the minor salivary glands of Weber present on the tonsil, superior pole of the tonsil, and then it can obstruct and then the infection can spread into the peritonsillar space. That is how the peritonsillar abscess develops. And usually, even though tonsillitis is bilateral, peritonsillitis occurs unilaterally. So the abscess develops in one side only. And tonsillitis is a disease of childhood. Like children are more prone to develop acute tonsillitis, but most commonly peritonsillar abscess is seen in an adult. What is the pathophysiology? That is, what are the organisms that causes peritonsillar abscess? The most common organism is Streptococcus. Streptococcus pyogenes group A beta hemolytic Streptococcus. Also, there can be Staphylococcus aureus. Also, methicillin-resistant Staph aureus are also found. Anaerobes like Fusobacterium, Haemophilus, etc. are also found in the peritonsillar abscess. It is usually a polymicrobial invasion. Sometimes peritonsillar abscess can develop following an Epstein-Barr virus infection also. What are the clinical features? The patient usually presents with severe throat pain. Usually it will be on the unilateral side, one side, unilateral severe throat pain. A history of throat pain will be present for 3 or 5 days prior to the severity. That is gradually progressing sore throat and throat pain and difficulty in swallowing. That is pain during swallowing, odynophagia, dysphagia. All this will be there. The patient can also have drooling and then there can be chills, malaise, fever, lethargy, associated symptoms. And patient can be dehydrated because of the pain. The patient won't be eating anything. So patient can come in a very dehydrated state also. The patient can also complain of a neck pain and also change in voice. Patient will report change in voice. Sometimes if the edema and the abscess is so big, patient can come with respiratory distress also. So on examination, you can see if the patient is drooling saliva. And if you're examining the mouth, you have to be careful. Don't put the tongue depressor and press open and all that. So generally, you have to ask the patient to open the mouth and examine. So you can find that the anterior pillar will be congested, tonsil will be enlarged, congested, and the tonsil will be pushed to medially, pushed inside the throat. That is because the abscess is forming here, the tonsil is pushed medially. There will be erythema and exudates over the tonsil. And also the soft palate will be edematous, erythematous, and the base of the uvula will be pushed to the opposite side. The entire thing is pushing, so base of the uvula will be pushed to the opposite side. Patient will have a change in voice that is known as hot potato voice due to the edema of the soft palate and the mass. Also there will be trismus, that is inability to open the jaw, pain while opening the jaw due to involvement of the pterygoid muscles. And also there will be torticollis, that is if this side is affected, the head will be tilted to the side so that patient will feel less pain. So there will be spasm of the muscle and the head will be tilted like this. Torticollis will be there. There will be cervical adenitis, that is the jugular-digastric nodes will be enlarged. So you will be able to palpate the jugular-digastric lymph nodes which can be tender. It's not so common in children, but children the examination is difficult. If the patient is presenting, especially if it is child can present with anxiety and respiratory distress. So in tripod position, that is leaning forward and sniffing position, in all drooling will be there. In all these cases, you have to first stabilize the airway and then only proceed with further examination. The diagnosis is mainly clinical from the history and your clinical examination. What are the other investigations that you can do for this patient? You can do a complete blood count. There will be leukocytosis, typically neutrophil predominance. And also, if the patient is dehydrated and have given history that not eating, not able to eat anything for a few days, you have to do all the urine acetone and all that, the blood glucose, urine acetone, all that has to be done. Also, you can test for Epstein-Barr virus. Heterophile antibody test can be done. The pus has to be aspirated from the peritonsillar abscess. I will come to it in a moment. And then that can be sent for gram staining and pus culture sensitivity. What are the radiographic investigations that you can do? You can do an ultrasound. Ultrasound will give you an idea of the abscess, and also you can do an ultrasound guided aspiration of the pus so that you can get the microbial diagnosis and the sensitivity of the antibiotic. If the ultrasound is not giving you a proper diagnosis, and if you are suspecting the spread of the abscess beyond peritonsillar space, if there is involvement of the parapharyngeal space, if you are suspecting some malignancy and all, you can go for a contrast enhanced CT of the neck also. What is the treatment? If the patient is coming with a respiratory distress, airway stabilization is the most important part. Once the airway is stabilized, you can proceed with the further management. The patient has to be admitted. You have to start the patient on IV antibiotics. You can start with amoxicillin, clavulanate, or you can use ampicillin, sulbactam, also clindamycin. If you are suspecting a methicillin resistant case, you will have to give vancomycin or linezolid. And simultaneously, you have to aspirate the pus for a pus culture sensitivity. In some cases, the aspiration itself will be curative. Also, associated pain control. You have to give the patient a strong painkiller because the patient will be in severe pain. And also anti-edema like your chimeral alpha, peptides. Also, a course of steroids can be given because especially if the patient is having some breathing difficulty, hot potato voice, the steroids along with antibiotic coverage will help reduce the edema and to stabilize the airway. And supportive treatment and like IV fluids has to be given. How do you do a needle aspiration? Always the patient has to be seated in a sitting position. It has to be done so that the patient doesn't aspirate, and you can spray the throat with the 10% lignocaine spray that is available. And a tongue depressor can be used to see the pulse properly, and use usually an 18 gauge needle with a 10 ml syringe and aspirate the pus. The needle aspiration, most commonly we have to do it at the maximum bulge area or at the superior pole of the tonsil. Keep aspirating until no pus is coming out. And that can be sent for pus culture sensitivity. And the patient can be given mouth gargle, saline mouth gargle and betadine mouth gargle. Also benzodiazepine, pain relieving mouth gargle can be given. What is the surgical management? Surgical management is incision and drainage of the peritonsillar abscess. I come from a school of thought where we say like never let the sun set on an abscess. Like if you think that there is pus collection, it is better to take the pus out. But some studies show that medical management can be done. There is not much difference between medical management and surgical management. But the same study says that if the abscess size is more than 2 centimeters, there is not much effectiveness for the medical management. In my practice, if there is an abscess, it is better to incise it and take the pus out. So we do the incision and drainage also in the sitting position. Patient is in the sitting position because we don't want the patient to aspirate any of the pus that we are draining. Sitting position, give local anesthesia, spraying, and also you can inject local anesthesia like 2% lignocaine you can inject. But because it is full of pus, the local anesthetic will not have much effectiveness. And you can put an incision. Usually the incision is made at the area of maximum bulge. For an approximation, you can keep this point like to draw a line from the base of the uvula to the antipillar and also straight vertical line along the antipillar. The point where it meets along the superior pole, you can put an incision. A small curvilinear incision can be done. You can use Sinclair Thompson Quinsy forceps which has a guard so that it will go only that much. And otherwise, you have to use a guarded 11 blade. What we used to do is we put a gauze or a micropore around it so that it does not go too much inside. If it goes too much inside, what will happen? It will prick onto the internal carotid artery. So you don't want too much of the forceps or the blade to go inside. In adult, the internal carotid artery lies 20 to 25 millimeter deep to the tonsillar fossa. So only 1 centimeter we should go. 2 centimeter means we will reach the internal carotid artery. So maximum 1 centimeter only we should go. That is why the Sinclair Thompson Quinsy forceps is having a guard. Same way you can guard a blade and do if it is not available. The pus has to be taken, suction has to be ready. Whatever it is has to be suctioned out. Before that, you take a swab and collect the pus and give for culture sensitivity. And the patient has to be asked to gargle and spit it. Whatever is there, you can ask the patient to spit. If little bit the patient swallow also, it is not a problem. And you can also give betadine gargle and pain reducing like local anesthetic gargles like benzodiazepine simultaneously. Immediately after the incision and drainage, patient will say that there is some relief of symptoms. but there will be edema which will be there for 1 week, but then gradually it will subside. We have to continue with the IV antibiotics and the topical mouth gargles. What is the indications for tonsillectomy? It is known as hot tonsillectomy or Quinsy tonsillectomy. If there is an intratonsillar abscess, you can do. Certain studies show that in children presenting with severe obstructive sleep apnea and tonsillar abscess, you can go for a tonsillectomy. Otherwise, we do an interval tonsillectomy. That is 6 weeks after the resolution of the infection, we can go for a tonsillectomy. Initially, it was said that one peritonsillar abscess, you have to go for an interval tonsillectomy. Now it is said that after the second peritonsillar abscess, an interval tonsillectomy is compulsorily done. A hot tonsillectomy or Quinsy tonsillectomy is more difficult because there will be more bleeding, and also the normal anatomy will be distorted due to the pus formation and erythema. So there is a more risk while doing a hot tonsillectomy. If the patient is resolving with your IV antibiotics and INT, wait and then go for an interval tonsillectomy. What is the prognosis? The prognosis is actually very good. If you do the incision drainage and give the patient proper antibiotic, the patient will recover within 7 days, 1 week maximum. And also there can be a chance of recurrence. 1 to 5% of cases, there is a chance of recurrence of peritonsillar abscess. And tonsillectomy, an interval tonsillectomy is offered after the second episode to prevent the recurrence. What are the differential diagnosis of a peritonsillar abscess? It can be any intratonsillar abscess. As I said previously, intratonsillar abscess. Peritonsillar cellulitis. In peritonsillitis, the uvula may not be deviated. Only the redness will be there, bulge will be there, but uvula may be in the center. At that point of time, if you start an antibiotic, it will get better. And you may not do an IND at that point. Peritonsillitis. Then other differential diagnosis are any mass, any parapharyngeal mass, or any parapharyngeal abscess, or a retropharyngeal abscess, or epiglottitis, any odontogenic infections that is producing an abscess. Another differential diagnosis, any mass of soft tonsil, benign or malignant masses of the tonsil, carcinoma of tonsil, any lymphoma, any carcinoma of the nasopharynx, also any minor salivary gland tumors. Other differential diagnosis, any vascular anomalies, that is any Kawasaki disease which is presenting as a peritonsillar swelling. Also any aneurysms of the internal carotid artery, post-traumatic pseudo-aneurysm of the internal carotid artery. Also you have to take a proper history. If you are suspecting a vascular anomaly, you can go for a CT angiogram along with the CEC. What are the complications? If the peritonsillar abscess is not properly treated, it can go in for multiple complications. It is very near to the parapharyngeal space, so the abscess can spread into the parapharyngeal space and cause a parapharyngeal abscess. There can be spontaneous rupture of the abscess, causing respiratory distress, which is a medical emergency. And also, once the abscess is spreading, the patient will have airway edema and respiratory distress. There can be suppression of the cervical lymph nodes, causing a submandibular edema. It can spread, causing Ludwig's angina. It can extend into the mediastinum, causing mediastinitis. And the internal carotid artery is there. Pseudo-aneurysm of the internal carotid artery can occur. Arterial rupture can occur. The internal jugular vein is also there. There can be suppurative thrombophlebitis of the internal jugular vein, known as Lemierre syndrome. The septic emboli can travel to the lungs, brain, etc., causing septicemia and shock. Also, necrotizing fasciitis can happen. Usually, peritonsillitis is diagnosed and treated, so we don't see this much complications happening, but these are all the potential complications that can happen if the peritonsillitis is not treated early and treated properly, and also if the patient is immunocompromised host and is not responding to the treatment.